There we go. Welcome, listeners, to the Fuck the Silos podcast. Uh, I'm Lawrence Yang, your host. I'm a family doctor in Surrey, and we have with me my new friend, Dr. Betty Tang. Dr. Betty Tang, you are a psychiatrist in Vancouver, aren't you?
Yes, Vancouver Coastal Health.
Yes, I had met you at one of the physician quality improvement days. I think it was day one or day zero. I can't remember which day it was for your level 3 cohort training.
It's
Yeah.
so exciting to be involved in this program.
Really? You like
Yeah,
it? Oh, I'm
yeah,
glad to hear.
yeah.
Um, Tell us a bit about yourself so the listeners can kind of orient and know a little bit more about you.
Sure. And thank you so much, Lawrence, for this opportunity. So I'm a psychiatrist. I started off mostly in child psychiatry in Fraser Health. So I got used to working in rural areas where there were slightly less silos, interestingly enough. And then I moved to Vancouver and worked for Vancouver Coastal Health and moved a bit into adult psychiatry. So I think that's interesting because I have a developmental perspective when I see adult patients. Hence, that's important for the ADHD consideration. And now I work for remote communities in coastal health that would otherwise have a great deal of difficulty accessing psychiatric services. So I'm still working for remote communities.
That's interesting. So you've tried two different health authorities at least in, or maybe even more than that, because you're hitting a remote patient. So patients may be in the interior or in the north.
No, still just the two health authorities, remote coastal, so
Okay. Okay.
Sunshine Coast, that kind of a thing.
Does that mean like places like Seychelles and stuff like that, or no?
Precisely.
Oh, okay, that's cool.
Yeah.
Beautiful,
Yeah.
beautiful country that is. So, what brought you into psychiatry? What was a little, tell us a little bit about your journey in choosing your specialty.
When I was young, no, that's probably a bit too long. When I was young, I really, really enjoyed reading. So actually, at first, I wanted to become a foreign correspondent, but little did I know I do not like traveling nor danger. So that lets that out. And then I was interested in kids and pediatrics, but that didn't suit me either fully. It was too technical in some ways. I think perhaps having my first rotation in the NICU was not a good place to start. But then I discovered psychiatry, and I really, really like a lot of it is detective work. I am trying to sort out what is contributing to somebody's functional impairment. I'll say that a lot today. What is contributing to their functional impairment? And it's not just as easy as saying, oh, you have depressed mood, you must be depressed, because that's like saying you have a fever, it must be pancreatitis. So I really like the detective diagnostic aspect of psychiatry, and there is so much overlay of psychology and social culture along with symptomatology for patients. I remember when I was applying for psychiatry residency, I wrote in my application letter, it really felt like a calling. Like I really, really feel honored that patients let me into their lives. They're vulnerable when they're talking with me. So there you have it.
It sounds like you're very empathic. It sounds like you love helping people, um, and it sounds like you're able to appreciate all the complexities, all the multiple factors that impact someone's psychological wellness. Is that right?
That's a small part of it. I'm aware of it, and I like being aware of it because every person is unique and different. Yes, we talk about statistics and there's common binding symptoms, which we'll get into, but we're not just a bag of 92 chemicals, because then that would be so easy. Like we just test all the chemicals and see what's wrong, and that's not how human beings work. So yes, like looking at all the factors that go into things, but also what factors I do have to weed out what actually doesn't play into what makes a diagnosis, right? So there are things which influence how people may present, but there are things which are extraneous to the actual diagnosis of psychiatry, which may be very pertinent to when you're talking to a psychologist, for example, right? So I want to acknowledge there's lots of different facets of a person, and I'm only one part when I'm doing the psychiatrizing.
So you've kind of highlighted for us a contrast between psychology and psychiatry. That there's, yeah. Mm.
Yes.
When you said, when you chose to say the number 92 here, that was just something you plucked out of the ether, right?
I think there's 92 chemicals on the periodic table, not counting the synthetic ones, but you know what? That's a long time ago that I was used to say that.
So one of the reasons that I brought you on the show today is because I'm very interested in the topic of um, executive functioning and attention deficit and hyperactivity disorder. What is what do those things mean to you? What is executive functioning? What does that mean to you?
Sure. And, this is a great question. And executive functioning and attention deficit hyperactivity disorder are not mutually inclusive nor exclusive. So, executive functioning is basically, like very simplistically, how we organize and manage tasks, how we figure out what to do when. And that can be affected by a number of factors, not just ADHD. People can have executive functioning difficulties and shifts in executive functioning if we haven't had enough to eat, if we haven't slept well, if we cannot see, if we have sleep apnea, if we have pain. So all those things affect our executive functioning. Executive functioning is being able to plan and organize our time and what we do with it. I can go into it in more detail, but to me, that's sort of the crux of it, right? There's definitely papers out there that break it down into, 6 or 7 domains or more. But I think for the purposes of this podcast, that might be too much detail. Yes.
Hmm. I think I heard, yeah, what you said is that so my executive functioning is my ability to plan what I'm going to do and when I'm going to do it. So almost like how am I going to strategically plan my day so that I achieve whatever outcome that I that would be good for myself and those that I care about. Yeah.
Yes. Yes.
And, mhm.
And being able to, in some ways, go with the flow, acknowledging that there's distractions, things that may take our attention away from what we were doing, being able to remember what we were doing, to go back to what we were doing at first, right? So there's different aspects of how do we organize and plan our day. I just want to put those out there because those are other subtleties that play into how things go, because we're not Ottomans in a factory. We don't just do things exactly a certain way just because we planned it. We have to be able to shift our attention, go with the flow, come back to the flow, and then regulate ourselves. Part of the emotional regulation aspect when we're frustrated because things didn't go away. How do we deal with that? How do we get back on track?
Ah, and I heard from you that when I'm hungry, when I'm tired, when I'm mad, or when I'm in pain, for example, these can all impact my
Yes.
executive functioning. My okay. Mm.
Absolutely. And, I'll put a few other things out there. People often say, my goodness, I used to do this well. How come I can't do it anymore? You just had 2 toddlers, right? What you could do before you had the children is not going to be the same because there's a cognitive load aspect. Too much cognitive load means you're not going to be able necessarily to maximize your battery indefinitely.
Mm. Yeah, so cognitive load, like the complexity of my daily life, factors into my capacity to plan
Yes,
and execute things. Mm,
absolutely.
that makes a lot of sense.
Thank you.
So, thank you. So, what does this have? There's a linkage, of course, with executive functioning and attention deficit hyperactivity disorder. Tell me more about ADHD. Tell me what is it? Yeah, what is it to you?
Yes. So a couple of key points. So ADHD is a neurodevelopmental disorder. So what that means is the brain's development, right? How your brain has developed in ADHD is such that your performance or functioning is affected from childhood. So ADHD doesn't just develop out of the ether in your 40s. Okay, no, that's the current research. I know there's some people out there who are, researching maybe other, rarities where maybe that does happen. Bottom line is, for this podcast, for most of us clinical practitioners, ADHD is a neurodevelopmental disorder that's been present since birth, really. And it's because the brain pathways that influence our performance or functioning is not as it is in a neurotypical person who does not have ADHD. And ADHD has very specific criteria. So when we talked about executive functioning, it's in itself not a diagnosis. ADHD is a formal psychiatric diagnosis that's based on meeting the criteria for several different kinds of symptoms, which are in some ways falsely dichotomized into inattentive and hyperactive, right? Then these symptoms have to cause functional impairment, have to be present before age 12, and have to be interrupting your optimal functioning in more than one setting. So 2 or more of your life settings.
Hmm. 2 or more life settings. Does that mean kind of like my setting at home and maybe my setting at work? Does those suffice, the 2 settings?
Sure, setting at work, setting at home, setting in social situations, setting in hobbies or other activities, vacation versus work, right? So these are all different settings also.
Ah, thank you. And mm, you mentioned a few words that I'd like to explore more. One was neurotypical. What does
Yes.
neurotypical mean?
Sure. Neurotypical is a term that people have coined for those who are not struggling with neurodevelopmental disorders.
Hmm. So if you don't have a diagnosed neurodevelopmental disorder, you're most likely neurotypical. Uh,
Yes.
and you kind of
Yes.
have to have an assessment to know if you're neurotypical.
Well, if you're not functionally impaired and you have no other symptoms, I think that's our fallback. Of
Okay.
course, we all have some impairments because, human beings are not automats and not perfect. But again, the crux of it is it functionally impairing? I could be annoying to my partner, but I do not believe it's functionally impairing at
Ah,
this time.
is functional impairment in the eye of the beholder?
It's interesting because I think functional impairment does depend a bit on what supports you have around you. That actually does make a difference to how the person with ADHD is able to function. But I will say, if somebody functions well, and we call it scaffolding in ADHD, if somebody functions well, we can still see clues because they may be requiring more supports or more scaffolding, and yes, doing well, but more compared to the neurotypical person. And that would be a clue that their functioning would actually be impaired if they did not have that level of supports or scaffolding.
Hmm. It's cool that you take into account that amount of support. And I like the term of scaffolding. It brings to mind all the stuff at the side of buildings and when they're trying to build it, things to support other things.
Yeah.
There was another thing you said. I think you mentioned something like a false dichotomy between hyperactivity and inattentiveness. Can you speak
Yes.
more to that?
Sure, that's what I've been starting to feel. And I want to specify this is not necessarily research based. This is something that I've been thinking about. So it's not necessarily evidence based, but just like people who have heart attacks, yeah, most everybody knows about the classic, gripping pain in the chest, radiating down your left arm. Nobody goes around calling that the classic heart attack syndrome, which is separate from the silent heart attack syndrome, because not everybody comes in with those classic symptoms. So when people say, well, do I have inattentive type or hyperactive type? It overall actually doesn't make much difference in the treatment. The treatment is more or less the same. What influences the treatment is how the patient responds, patient's personal preferences, other aspects of the patient's history, such as comorbidity, which is a fancy word for saying, what other things are they struggling with that's not just ADHD. So when I think about inattentive symptoms, oftentimes, and this is interesting, okay, because when I saw children in child psychiatry, it makes sense. They didn't quite have the language to explain what was going on. Other people could see they weren't paying attention, they weren't focusing, they were concentrating. Now, as adults, they're telling me that they have too much going on in their brain. Their brain, they did not recognize this until they got treatment for their ADHD. They said, I didn't know my brain could be quiet. All right. So is inattentive them having hyperactivity in their brain? Is that another way of looking at that?
Oh,
So
so it's like,
I find that just interesting when
it's not two things. It could be one thing. It's just the hyperactivity is happening in the brain.
it could be a different way of how it is expressed, right? We talk about phenotypes, and we know that women and men often present differently in other medical conditions. And so we're finding also now that they often present differently in psychiatric conditions, including ADHD. So many of my adult ADHD patients actually were never diagnosed when they were younger because they weren't hyperactive. They were having difficulties with focusing and paying attention and getting things in on time, and talked about having a lot of last minute panic, but are bright and creative and did well enough in school. So the impairment was not seen in getting poor grades. The impairment came out in lack of sleep, doing things last minute, their parents being upset with them because why didn't you plan ahead, pulling the fat of the fire out of the fire at 2 a.m. before the science poster was due, which they started the night before at 9 p.m., for example. So I hear these stories repeatedly. So were they functionally impaired? Not if you just looked at their surface grades, but for sure, if you look at their mood and anxiety and lack of sleep and a bit of the background chaos.
Wow.
So I
Feel
find
like you
that
were. I feel
very
like you were.
interesting.
I feel like you've been talking to my mother or something.
Oh,
I was one of those last minute homework guys, and I did do quite well in school anyhow. But
sure, sure. But I do want to point out there, thank you for bringing that up. That is not necessarily pathognomonic for ADHD either,
mm,
because we don't have the same expectations necessarily for a 4-year-old as a 14-year-old, as a 24-year-old. So many people also say, which is totally fair, well, my teenager was like this. Did they have ADHD? Or, well, doesn't everybody do this in first year university? Fair enough. Yes. The very interesting thing is, can you learn from it? So my poor patients with ADHD, they work hard. They work hard at trying to do executive functioning. They try to figure out how to get things done so they're not always doing things last minute or feeling like they're behind everybody else in the adulting, is one of the terms one of them actually used. The thing is, they can't. They try so hard, and they can't. It's not that they can't learn executive functioning. They can't get their time there. They can't focus and concentrate well enough. They can't remember well enough all the things they put on their 3 Google calendars that they check every 15 minutes to try to make sure they stay on time. So the amount of effort some of my patients have put in to surface level keep up and maintain a level of functioning. So again, you're working, let's say you're an engineer, right? All right, very bright. Okay. Yeah, you're putting in 18 hours a day and you're getting out 8 hours. So that is the functional impairment also. So a
Wow.
lot of these people get missed because they've overcompensated and now they're being referred for chronic depression and anxiety because the ADHD is not being thought of.
Oh, wow. So I think what you're highlighting here is that if someone doesn't have treatment for ADHD, that it can turn into or manifest as anxiety and depression.
Absolutely. There are high levels of comorbidity, and you again, they are not mutually exclusive or mutually inclusive. I have people when you treat the anxiety and the mood actually improves dramatically because the mood, and notice I'm not using the word depression, I'm using the word mood because there is some difference in how they present the symptomatology. The people who have ADHD that has not yet developed into more classic depression, they will talk about having low self-esteem, being chronically frustrated, unhappy, unable to enjoy activities because they're so busy checking their calendars and trying to send their notifications. They don't have time to enjoy their family life, for example. And they may score high on the rating scales we use for depression. But when you talk to them about what they're depressed about or how they're depressed, it often is as a result of the consequences of ADHD, which is not quite the same as I just wake up, do not enjoy anything, even if there's nothing for me to worry about. I cannot get out of bed. I cannot think, I cannot work. I am not motivated. People with ADHD will talk about lack of motivation, but it's a different quality. They want to do it. They just can't get themselves to do it. Where somebody with depression, they might have wanted to do it before. They might even want to do it now. But what's the point? There's a different quality when I talk to
Wow.
people.
Wow. Okay.
Yeah,
So it is a different quality of ADHD related depression in most cases than major depression without ADHD. It feels you can kind of see a different path.
I, I
Yeah.
do try to sort it out. And again, oftentimes I talk to patients about my formulations and hypotheses because sometimes it may be that the depression is actually taken on a life of its own. There has been so much negative self-cognitions and how much we've internalized about the difficulties we've had with our ADHD that yes, now we do have trouble with our energy and difficulty getting out of bed, and we cannot enjoy the activities we used to enjoy despite the ADHD. So the reason I do try to do that is because I want to figure out what do we go after first? Do we treat the ADHD first or do we treat the depression first? And sometimes I treat the ADHD first. And I'm like, oh, I made their mood worse. They actually feel worse. There's side effects. So I need to treat the depression first and then I can treat the ADHD. And now it's all good.
Oh,
Now, you
wow.
might say, well, why even bother treating the ADHD if you treated the depression first? Okay, I treat the depression first. Oh, look at that. They really didn't have ADHD. It was all depression because when you have depressed mood, it's hard to concentrate and focus and organize and get things done. But just to put out there, I like to think I very rarely misdiagnose adult ADHD because I've made the time to go back into their childhood and see what came first. And for the people who do have ADHD, you go back into their childhood and you can see, oh, yes, they were described in the teacher report cards as exuberant, lovely, helpful, if only they could concentrate and not talk to their friends, distracting their friends so much, right? These are calm, but they weren't depressed then. And now as an adult, they're presenting for depression, but there were already clues for the ADHD in their childhood.
Wow. Some of our some of our listeners are parents. Some of our listeners
Yes.
might even be teachers at a school. Some of our listeners are family doctors. And what are some of the clues that somebody needs to see someone for a diagnosis? What are some of those clues? Is it that like they seem to be losing attention all the time. They're not getting their homework done. Is that really what it is?
Well, I will acknowledge that in childhood, unless it's more classic symptoms, it can be hard to tell because there is so much development going on. There's so much development going on in childhood. You're not fully formed yet. And you talked about your, mother saying that you were disorganized and did things last minute. Well, here's the thing. Was that simply because you hadn't learned executive functioning skills yet? Because I want to put out there, those are learned um, techniques. So, first year university, guess who ate poorly and slept poorly and didn't organize their time well? I'll put my hand up. Did I figure out quickly that this was a bad way to be? Indeed. Did we start to keep a chore wheel? Did we start to write in a scheduler? Did we start to um, go grocery shopping at a dedicated time once a week? So these are things that can be learned. And when you are a parent of a child who is struggling, I think the first step is to see, are there some things we can help them learn? Do we teach them to say, hey, maybe 5 minutes before you go to bed? Oh, it's a whole other question, a whole other topic there. But, why don't we learn to put your book bag together the night before? So this is a learned behavior. This might help with the morning routine so we're not late for school every day. Now, I would say that around grades, well, even younger maybe, depending on the child, the structure of the family, grade 4 to 6, perhaps a younger person could learn to do that. I've had adults with ADHD say they never learned to do that, and their parent just simply did it for them. That's the scaffolding. It was just too much fight to keep doing it. Now, somebody might say, well, I tried for 3 times and okay, you know what? 3 times is not long enough. Like maybe give it 3 to 6 months, right? You have to give it time. Developmental age learning process. Didn't take the first 3 months of grade 3. All right, see what else you can do. Maybe we can start in the beginning of grade 4, right? But the trajectory is really helpful for me when I see the adults. So I appreciate that when you're younger, perhaps it's not fully figured out yet. And the other thing is to make sure, everybody says it, but limiting the screen time, making sure that they go to bed at a proper time. Are they eating reasonably healthy? Are they getting appropriate exercise? All these things can be helpful, not just for the young person, for the older person too. But this is where we would often start with the young people. Now, people who have more significant deficits, yes, you'd probably want to see your family doctor and pediatrician sooner than later, especially if there is a family history of ADHD. We know it's highly heritable. Many times parents have come in and done the checklists when, for their kids and said, oh my gosh, this was me then, and this is still me now. So this is also very interesting. So if there's a family history, other clues that might increase a child's risk, another reason to have the pediatrician, school counselor, teacher be aware of it, have school accommodations more readily available to that young person sooner rather than later.
And ADHD can be diagnosed by a psychiatrist like yourself, or a
Yes.
family doctor like myself, or
Yes.
a psychologist, right? Are those the three that can diagnose ADHD, or are
You
there?
know what? I would put out there, I mean, I highly doubt this would happen, but an ophthalmologist who is well aware of the criteria and the need to get information from multiple domains and looking at the trajectory and development, a physician can diagnose. I mean, I highly doubt an ophthalmologist would, but
Mhm.
mostly it's family physicians, pediatricians, psychiatrists, and for kids, probably child psychiatrists as opposed to adult psychiatrists, and psychologists can also make the diagnosis. What psychologists cannot do is prescribe medication, but they're often very well aware of the medications and can advise physician colleagues who may be less aware.
When I was Googling ADHD before this call, it said that about 4.5 to 5% of adults probably have ADHD. Does that number resonate with your experience?
Yes. It also resonates with the epidemiological studies that have been done, which are published.
Oh wow, 4 to 5%.
Yes.
So out of every 20 people, there's about one person who has uh, who meets the criteria for ADHD.
Yes.
Hmm. Is now what might people not know about ADHD already? What are some things that you think the public should know about, our listeners should know about ADHD? Are there any
Yeah.
myths that should be busted about ADHD? Can people heal from ADHD? Can it just go away if they, I don't know. I don't know what how to
No,
heal it. No?
no, I think
Like
of it like
okay.
diabetes. It's not curable.
It's a
It is
chronic disease.
certainly manageable with both pharmacologic and non-pharmacologic treatments. Absolutely. Oh, so many myths. This is a huge question. All right, I'll give you some myths. People with ADHD just want addicting drugs.
Ooh,
People with ADHD just need to work harder. So many of my poor
I've heard that
friends
one.
have been called lazy throughout their lifetime. It's awful. Yeah. They're often told, I'm going off on a tangent here, this is not one of the myths, but they've been told they could reach their potential if only they tried harder. And the refrain, how do I try harder? I don't know how to try harder. Yeah.
Hmm.
Contributing to anxiety, depression, low self-esteem, feeling like it's a character flaw, ADHD, as opposed to a neurodevelopmental disorder. Imagine if he told patients with asthma just to breathe harder,
Yeah.
right? Yeah.
Mhm.
Another one I love. Well, they got A's and B's in high school, therefore they can't possibly have ADHD. So a huge myth is that if you have ADHD, you must not do well in school. Nothing could be further from the truth. I have people who are extremely, extremely interested in learning, highly creative, intelligent. One of their domains of functioning poorly may not actually be school. Having said that, they may do excellent in the courses they're very interested in and get F's in the courses they're not. So that's not about lazy. So I get a lot of people, well, are they just being oppositional? They just don't do what they don't want to do. It's about they know the importance of it. If I don't want to do something, but I know it's important, it's a mandatory course, I just got to get it done. I might procrastinate. We all do, but I will get it done. Oh, with a bit more effort than if it was something I was interested in. The poor person will fail their 4-year degree on that one course. And they're not stupid. They wouldn't do that if they could get it done. So I think that's the difference. So one of the leaders in ADHD, Russell Barkley. I went to a talk from him back in the day when I was much younger, and he said, ADHD is a misnomer because people say, well, ADHD they can't pay attention. No, they can't pay attention as well on something they're interested in, something that's more onerous, something that's boring. It feels like a huge wall, as opposed to just a little puddle to step over. So he said ADHD should actually be called intention deficit disorder. And I love it because it's the intentionality of how you split your attention, sustain your attention, manage your attention. That's the issue, not whether you can pay attention. It's how do you intend to use your ability to pay attention,
So
not me.
wait. I think did you just say that he was it Russell? He said that ADHD could be called intention deficit. So
Yeah.
I have a deficit of intention to focus.
I have a deficit of how I intend to focus my attention.
Oh, I have a deficit of how I intend to focus my attention. And that deficit of intention is not my fault. It's what I was born with. It's a chronic disease that I was born with. Chronic disease
It's a
is a lack of intention.
yes,
Oh,
yes.
wow.
Difficulties and how do I say this? Because I want to acknowledge I'm also not a basic scientist, and so a lot of my understanding of the biology of the brain may not be as good as people involved in research. But yeah, it's basically the wiring, the levels of neurotransmitters are not in the right balance to be at the same pace as our peers. So that's the other thing. When you're looking at functioning, we're looking at what is within normal limits. So it is not reasonable to expect human beings to be able to focus for 18 hours straight. Can we if we have to? Sure. Is it to be expected as a usual thing? No. If we do not have ADHD, can we do it because our brain is able to adapt and regulate the balance of neurotransmitters? Sure. But it might not be as good if we didn't sleep well the night before, or if we had a screaming toddler 5 minutes ago, or what have you. I will say that the adults I have with ADHD, we do talk about the cognitive load and the battery. And because they have to focus so hard on focusing, right? You have to focus on focusing. You add one thing and you can't do it. May I give you an example from a
Yes,
patient?
I'd like to
Sure,
hear an example, and also if you could expand on your concept of battery, that would help me
sure.
too.
Sure, I think my patient case will help with the battery. So this is a patient which is an every person patient. I've changed the names and the details, but I believe that many people can relate to it, and it's not going to identify this person at all. So we will call this person Sal, and we will call them they. And they are very bright, creative, have a good job, which they do well in and they enjoy. They recognize that their job has a lot of structure. They have things that have to be done, which are creative, and there are deadlines. Work has deadlines, and people to tell where they're at. So that's helpful. So, and they have a partner. They have a partner who naturally, it just happened, took on much of the home functioning, organizing chores, getting groceries, paying the bills. The partner looked after that, and it was fine. It was happy. It was no issue. Then they had a child. This is always a difficult time for parents. I want to acknowledge everybody's sleep deprived. Nobody is able to do all the things they want to do. There is now another little person to look after. But this cognitive load, this battery, the partner was still able to do what they typically did and take on some of the additional responsibilities, of course, of the young child, later toddler. The person with ADHD could not. They did not have any battery left over after their work day to now look after the child in the evening. In the past, they now recognized they would relax while their partner got dinner, did some basic chores. They would be helpful to the partner. The partner might say, oh, can you get this and that for me? No problem. But now the partner was not able to do that because they would be attending to the screaming child. And then lots of things were not happening in a partnership in the home for the family life, which now included the toddler. So that would be an example of the myth that this person did not have ADHD because they did well in work and previously looked like they did well, but there were clues. And I've left out, some of the other things, when the partner said, honey, can you pay the bill today? They would say, sure. And then they would forget to tell their partner. And now there would be a couple of hundred in fines, for example, right? These are the stories I get. So these are the clues to the functional impairments. Right. And these kinds of things wouldn't happen just as a one-off. It could happen to anybody as a one-off, but they would happen repeatedly, little clues, right? And then the partner would absorb it or accommodate for it or learn to deal with it. Now with a child, they could not. Now, when their ADHD got treated, this is the fascinating part because they did have ADHD. And again, the report cards had clues. Nobody noticed the clues because they did well academically. But yes, last minute, disturbed their friends if were finished early, as opposed to keeping themselves quietly amused, that kind of a thing. When they were treated, what this patient noted was they could now, if there was a child who was unhappy, they now had the ability to think about it, sit with it, think about different options of how to amuse or console the child, rather than being overwhelmed by the external stimulation and having no battery. They now have the battery to organize their thinking, think about what to do when, choose something to do with their child, with which their child could respond appropriately to. So now they're having a better parent-child relationship, as well as a better partner relationship. So there is a window into somebody's functional impairment with ADHD, primarily came out at home and not at work, but it came out not just in their relationships, social relationship with their family, came out in other ways with friendships, came out in their ability to get bills paid on time, came out in their ability to contribute to the household functioning, with external things that needed to be done, like grocery shopping, making appointments to bring the car in, other things that are onerous and not hard to do. Like, that's the thing. They weren't anxious about it. They weren't socially worried about talking to somebody on the phone. They weren't depressed and couldn't do it. It's just really boring and not on their radar every single day for a couple of years anyway. So that's Sal.
So yeah, that illustrates that many people who are in relationships where one partner is frustrated by the other partner's lack of contribution or apparent quote unquote laziness, um or they're overwhelmed, or they're really low battery, so they look like they're really maybe fatigued or overwhelmed after work. This might be a clue that there may be an untreated ADHD there. Yeah.
Especially if, looking back, it's happened since childhood.
Yes, so we have to have the history of since childhood. And when we actually try to make these diagnoses, do we have to get corroboration from like a parent or a guardian or a sibling? Is that how you usually do it, or?
I want to acknowledge we're not expecting all our wonderful siloed family physicians to be chasing after 40-year-old report cards. All right, that's not the expectation. People who are family physicians know their patients well, right? You may have birthed them, right? And you're like, where is a Toma? We'll call them Toma, and we will call them they. We've known Tomas ever, like, we birthed them, and we knew their parents too. They were always late. Toma is still always late. They're always late for getting their vaccinations. When they come in, they're always apologizing because they didn't adjudge the parking or the traffic appropriately, even though it's been the same parking and traffic since forever. Toma always looks like they're quite distracted. They are always fidgeting and fiddling and going off on tangents, and they just can't sit still. These are clues. You're the collateral in this case too, eh? Yeah. So just to put out there, family physicians are well situated to be longitudinal observers of their patients.
Yeah. So we can take what we know of the patient, some of these traits that might fit the criteria, and then is the ASRS, is that still the best
Yes.
validated tool to start with?
For adults, ASRS is specifically for adults. I know for kids, they use a different rating scale, also validated for kids, but I like to use the ASRS and the Wender Utah rating scale. There is a short Wender Utah of 25 questions. They're both ticky box things.
Can you spell that for me? I'm gonna Google it. What?
Yeah, Wender Utah, WENDER, Utah, UTAH. And
Wender, Utah.
And the Wender Utah is also validated for self-report childhood symptoms. So here's the other thing I want to say about people who have ADHD. When you ask them about symptoms, a lot of times they're like, well, I kind of looked it up and I wondered about it, but they often don't know. So here's some quotes that I remember. I never knew my brain could be quiet. I mentioned that one already. I did not realize that everybody did not take an hour to get ready to study. So they would be at university with their peers for the first time, because maybe in high school they just, did it by themselves with their, mom or dad helping them last minute. And they would, go to study group sure and be like, whoa, how come everybody's just taking their book out and they open the page and they're starting to read? Like they're like, that really happens? I've had people who've done that and said that like that to me. And then I remember this. Isn't it normal to be losing something every day? And I said, no. So if you have a neurodevelopmental condition, which you've had since birth because your neurodevelopment was not typical, how do you know what is supposed to be normal unless you've been able to make observations around you, which if you're inattentive and tending to zone out, that is difficult. So when you're asking these poor patients symptoms, I don't generally leave it open-ended too long. Like I know that having open-ended questions is the best way to like get people to tell you their story, but I help them along by saying, well, is it kind of like this, like, and then I jog their memory and then they give me their own examples.
Mm,
Yeah, so they might not think of the example right off the bat. It's very interesting working with people with ADHD, as well as, because I work in a general psychiatric clinic, my depression and anxiety patients present very differently when they do not
mm,
have ADHD compared to people with ADHD. There is a difference in how they present information and
mm,
how they relay their thoughts. How their thoughts are organized is not the same. And I can also see a difference when I treat the ADHD. Their thoughts are more organized. They
mm,
start to write things down that I tell them. Um, they start to be able to, you can just see the organization of the thought processes is
mm.
different. All right. So now I've gone off on a tangent. Um, and you were asking me about,
Oh yes, I actually had wanted to review some of the things on this Wender Utah. There's so active, being very active or restless, always on the go, uh,
yes,
easily distracted, fidgety,
yes,
inattentive daydreaming, short-tempered, uh, shy and sensitive, um, stubborn, strong-willed, sad or blue, incautious, daredevilish, involved in
right.
pranks.
Yeah, this is the long version you've got up here, but yes,
Oh,
this is the Winder, Utah.
mm, impulsive, unpopular, tomboyish,
Yeah.
getting into fights, leader, bossy. And it doesn't mean that every patient with ADHD has all of these.
Oh,
No,
goodness, no.
no.
Goodness, no. Because everybody does present differently. So some people with ADHD, well, many people with ADHD, often they wonder if they have OCD because they've developed perfectionism, or other people comment on this. You keep checking and double checking so long, it's taking you hours. Yeah, they're double checking because they've been told repeatedly that they make careless mistakes. And then they keep checking, and yet they still had another mistake. So
So people develop these patterns of behavior,
compensatory.
compensatory patterns of behavior because of the social challenges of living with ADHD. Mm,
Yes. I had another patient. They said, well, I've been diagnosed with OCD, and I think I have OCD because if I clean my house, I don't let anybody sit on anything. I don't want them to move anything out of place. And I asked why. It wasn't this compulsion that things had to be a certain way. It's because it took them so long to clean.
mm. Wasn't a compulsion. It was just that the effort they had put in was so
Precisely.
massive
So
that
massive.
it would destroy that,
Yes.
or negate that effort. Mm.
Yes. Yes.
So we've talked about how ADHD now is a is a problem, is a chronic disease that someone can get because of because their brain development. was
Yes.
different from the typical person. So that's how you get it. It's not that, yeah, it's not a personality trait. It's actually some some issue. It's actually a problem in the brain.
Yeah. Yeah.
And do you know what causes this difference in the brain? Like, how do people get ADHD?
So a lot of like, so 80% of ADHD, this has been researched and studied too, is genetic. There's a family history of it. You can get stories that, oh, you know what, dad was never diagnosed, but he couldn't survive without mom. Dad was fidgety. He couldn't keep anything in his head. It was totally scatterbrained. Mom like organized the household, for example.
Mm.
So
So there's a lot of scaffolding. There was a lot of
yes,
scaffolding, and that's how they. So what are the other types of scaffolding? So there's family support, there's spousal support. Um, what other types of scaffolding that are common that come to mind for you when you
yeah,
think about things that
structure,
hide it?
structure,
Structure. So a
structure.
culture,
So so
culture
in
has.
so in the what I call the old days, the army was a great place for people with ADHD, highly structured.
Ooh, so like a lot of people probably had ADHD, and then they're like, send them to the army, and
Yeah, for various reasons, right?
it
Like
would
people
give them
used to think that
structure.
would build character. But you know what? I want to put out there, so many of my poor patients with ADHD, they feel like this is a character flaw. They're lazy, right? It is not, and I say this over and over, it is not a character flaw. It would be like saying somebody with asthma has a character flaw. So
Mm, thank you. Thank you. You're trying to reduce the stigma around this neurodevelopmental challenge that people are facing.
yes.
Mm.
And this is interesting. I want to put out there another myth. We're going to talk about myths again, is that ADHD is overdiagnosed. Like everybody and their second cousin, it feels like wants to know if they have ADHD. It's in the media now, and people are talking about it. And actually, one of the reasons I reached out to you and said, hey, do you want to talk about ADHD and executive functioning on your podcast, is one of the adults I diagnosed with ADHD, we'll call them Ollie, talked about the stigma. They had not disclosed that they were recently diagnosed with ADHD, but peers had commented to them about they were taking their work more seriously this year. They were happy for them. Their mother told Ollie that you seem much happier. They had been treated in the past for depression, but now they are not on any antidepressant, only treated for ADHD. You're much happier, and your thoughts and your writings make more sense. Like they're clear. So
Mm.
that's interesting feedback from their parent. And Ollie at their school was saying that she just overheard some people talking, and they were saying, ADHD is overdiagnosed, it's an excuse, and it's not real. It's just people trying to get stimulants so they can do better in school. So a few more things to say. If you do not have ADHD, then sure, stimulants can help anybody concentrate better for a bit longer, but not long term, not sustainable, and probably bad for you because now you're at higher risk of developing other things like psychosis and other potential difficulties. So, in point of fact, if you do not have ADHD, it's not helping you. People with ADHD, this is normal amount of neurotransmitter. This is too little. We cannot focus. We cannot concentrate. We're unable to organize. We do not know what to do when. We can't figure it out. We feel overwhelmed. We're getting to hear, oh, look, I've had people say this. I feel like this must be what normal feels like. I no longer have to write every single thing down every single time. And people have made fun of them. Why are you writing this down? Yeah, because I can't remember, right? Like they're constantly pulling compensatory mechanism, constantly pulling their notebook out so they can write it down. Um, we're not going to hear. This is where it's too much neurotransmitter. Now we're at risk of all sorts of side effects of having too much neurotransmitter. So for people with ADHD, we're going from here to here. We're not wanting to go to here, if that's helpful.
Ah.
So
So when we treat patients with ADHD with stimulants, or methylphenidate is a common one. Uh, we're actually trying to bring their neurotransmitters to the normal threshold and
Yes.
not beyond that. And if we
No.
did, we would get side effects.
Yeah. And they actually have said, I mean, patients have said, this doesn't feel good. I feel jittery. This doesn't feel natural.
Okay. And if someone did not have ADHD and tried to use ADHD medications, I don't know how they source it, maybe on the street or were misdiagnosed with it, they would get potentially side effects because their neurotransmitters are already at the normal place. And if you take the medication, your neurotransmitters might go too high.
Right.
Okay.
Now, I do want to point out, because I've had people with ADHD, when they took methylphenidate, they said it felt like they had 10 espressos. This is not a good feeling. So just because you have the side effects doesn't mean you don't have ADHD. That was simply the wrong medication for that person. So again, we always go back. Did I diagnose it properly? Did I go through the criteria? Was I missing something else, right? So I also want to acknowledge that the diagnosis of anything in psychiatry, really, it does also say not better explained by something else going on. So, you know, can we be wrong? Sure. So if something is not responding to the medication as we would expect, is it the wrong medication? Is it the wrong medication dose? Is the person not taking the medication as prescribed? Do I have the wrong diagnosis, right? These are all the things we go back to if it's not going as we would expect.
I've actually had this conversation, I want to say it was 2 days ago. I was sitting with a bunch of family doctors, and the family doctors were actually mentioning more and more people are asking me to diagnose ADHD. More and more people in my clinic, patients. But I'm not fully comfortable doing that. I just don't have the experience to do it. And I'm so nervous about prescribing these stimulant medications because of the side effects and the risks. What do you have to say to these physicians, if anything? Physicians like family doctors who are worried.
Yeah. Oh, I'm so sorry. I'm so sorry that there's not enough um information out there, although I hope that's growing. I will say, I think it's like anything else. You're not comfortable with what you don't know about, right? So in medical school, back in the day, I don't know how it's been more recently, but ADHD was thought to be a childhood disorder. You grew out of it. We know that is not true. The symptoms can change in the life trajectory, and people who were very hyperactive as children may not be hyperactive physically as adults, but they may be functionally impaired more with the executive functioning and inattentive symptoms and being hyperactive in their brain, or the hyperactivity comes out in impulsivity or doing risky behaviors. And now we're being diagnosed with borderline personality disorder. And but that's a whole other topic. All right. Again, not mutually exclusive or inclusive. Haha. So what I would say to those family doctors is there is more help out there. There are development of courses and algorithms to help family physicians to diagnose ADHD. And we're not expecting family physicians to be psychiatrists, because we want to acknowledge you are supposed to be endocrinologists, MSK specialists, cardiologists, immunologists, respirologists. I'm sure I've left a whole bunch of things out. Um, but, I acknowledge that you guys are doing everything cornerstone of our system. Thank you so much. But for ADHD specifically, are there some things you can do that are helpful? Yes, you can do the ASRS and you can do the Winder Utah. You can see if the patient has symptoms that screen positive. So a positive screen is not diagnostic. I want to emphasize that. These are screening tools, not diagnosis tools. So you can have a more fulsome discussion the next appointment about their childhood history. If there is collateral, you asked about collateral. Yes, it is lovely to get collateral if it is possible. Some patients their parents have kept the report cards, that they can find them easily and bring them in. This is lovely when that can happen, but we're not expecting you to, go back and get them, expedited from, overseas or something.
And the
Fine.
report cards, you're not looking for the grade letter. You're looking for the comments, right? You look for the comments for
Exactly.
what the
Yeah.
doesn't seem to pay attention in class is always pulling pranks on their
Yeah.
classmates.
Or it was actually very interesting because once I had a 19-year-old, so just adult, right? 19-year-old, and the mom and the kid were like, no, never had ADHD. Like, great kid. No, I don't know where this came from. And now they're wondering about ADHD and at university, like, well, this is news to us. When they still had the report cards, the kid had only turned 19. Oh, Joey, not their real name. Joey is a lovely child, so pleasant, so helpful, does good work when he gets it done, does drift off in class, needs to be redirected, but it's very pleasant, doesn't get irritable. We just need to keep reminding him to do his work. But because they were getting good grades, the teachers didn't flag it, parents thought nothing of it.
But just needed to be reminded a lot, a lot of a lot of scaffolding.
Yes, exactly. So I do want to speak just a little bit about that comment my patient Ollie made about classmates saying, well, it's overdiagnosed, it's not real. So I will say higher awareness of it means it's hopefully being properly diagnosed. I had a colleague who was giving a talk on this exact thing. Is ADHD overdiagnosed? The issue is not whether it's overdiagnosed. The issue is, does the patient in front of me have ADHD or does not have ADHD? That is the crux of it. So I do believe that in the old days, there is absolutely chronic anxiety and treatment resistant depression. The interesting question to me is, how many of those people who've been diagnosed with chronic anxiety and treatment resistant depression have chronic symptoms and are not responding to treatment, therefore called treatment resistance, because they have undiagnosed and unrecognized ADHD? So that's the first thing. The second thing is society. So just want to put it out there, and I know you have the same thing. I will put out there, I do not have ADHD. Traditionally, I've been very organized. I know what I'm doing when. I may not always do what I want to do when, but I know why. Unlike people with ADHD who say, I don't know where the time has gone. I just opened my phone for 5 minutes and 2 hours have gone away. No, I know exactly what I've done in the past 2 hours. Yeah, I know what's happened with my time, right? So executive functioning is intact. However, societal expectations make me feel like I have ADHD sometimes. And I'm sure that people because ADHD is not necessarily you have it or you don't. I think it's on a spectrum. So people who were on the milder end of it in the old days got through school okay enough. Perhaps they were more sociable and extroverted, found a lovely job in customer service. Perhaps they were a traveling salesman. They sold their wares and they took the money. Let's pretend everything was $10 each. Very easy, right? Not too much math to work out. And then, they had a good day's work and everybody's happy. Now they got to file expense reports, document, do all the invoicing, write customer service reports on every single person they interacted with in case somebody complains about something. This is crazy making. And, and now we have so much documentation to do. In the old days, I would just write a prescription. Now I got to do 3 or 4 clicks to get into the EMR, 5 more clicks to get into the prescription pad on the EMR. And then I got to do some more fancy things, assuming the technology works, to get my email prescription to the pharmacy fax, which is invariably lost in the fax. So I got to refax it. So societal expectations increases cognitive load, reducing our battery. Therefore, people who had mild or perhaps almost negligible symptoms of ADHD are now exhibiting more moderate impairments. We
Mm,
saw this a lot during COVID too, right? People who were functioning well, reasonably well enough in the office, somebody said, because I could see all my colleagues working, so I had better work too. Now they're at home trying to do work from home. Yes.
mm. So let's say that someone gets diagnosed with ADHD and they're reticent to try the medications, knowing that the medications are some of the most uh, impactful things because it changes the neurotransmitters. And as long as they take their medication daily, they can probably improve their functioning, improve their relationships, improve their life, improve their um, performance at work, um, improve their longevity, reduce accidents, uh, reduce their impulsive behaviors. Like,
Improve their medical status.
yes,
ADHD is related to a host of medical conditions also.
uh, such as like uh,
Obesity,
obesity, like yeah, some binge eating is linked as well.
indeed.
Something that I know a little bit about. And so let's say that they either are on therapy or are not, medical therapy, pharmacotherapy.
Yes.
What are some of the non-pharma things? We've talked a lot about scaffolding from other
Yes.
people, but what if someone doesn't have that many people to be their scaffolding?
Yes.
What are some things that might improve their functioning? You
Yeah.
mentioned writing in notebooks. You mentioned Google Calendars. What what else might help that you've
So
heard?
there are executive functioning skills resources on the internet, like How to ADHD by Jessica McCabe, Atomic Habits. These are things I tell patients. Atomic Habits is a book that's available on Spotify and Audible by James Clear. It is full of executive functioning tips and tricks. cbtskills.ca is province-wide in BC and has recently been developing an executive functioning skills group for people with ADHD. So absolutely, executive functioning skills, super helpful. In fact, medications have a certain effect size. Executive functioning skills have a certain effect size. The both is better than simply one alone or the other. And that makes sense. I've had people who have ADHD, and it goes both ways. They say, I've tried so much counseling, it doesn't work. Sure, because they struggled to pay attention and not zone out. It's hard to learn the skills when you struggle to pay attention. But I've also had people, they can now pay attention. It's wonderful. They're like, wow, I can pay attention, but I'm paying attention to the very interesting Reddit article, not the coursework I have to do for, tomorrow or 2 days from now. So learning how to organize, prioritize, like my kid with the book bag the night before, that's a learned skill, right? These skills may need to be learned for someone with adult ADHD who has not learned them before or kind of knows, but maybe not in a formal way. And it can be helpful to learn it in a more formal way. I will put out there that not everybody with ADHD doesn't know how to organize. I have had people with ADHD who've developed very excellent organizational skills, but they're functionally impaired because of their forgetfulness and difficulty with shifting attention, right? My guy with the 3 Google calendars was checking it every 50 minutes to try to remember. Once they could pay attention, they had, 1 Google calendar they looked at twice a day or something. So did they need executive functioning skills? Not the same way as someone else who didn't even know how to, write in a scheduler.
I want to review some of those resources that you had just mentioned. I'm going to show on screen. This one is that this book is a book by Jessica McCabe. It's called
Sure.
How to ADHD. Is that one of the ones that you like?
That is Jessica McCabe, yes, that's the right person. But the How to ADHD, I'm thinking of her YouTube series because it's not a
Oh,
book that the poor person with ADHD has to read. She has videos that she's
okay.
demonstrating. Yeah, they're really
Okay.
funny. Yeah.
So let's let's check
I
that
mean,
out.
the book I'm sure is also excellent, but it's the YouTube videos that I was thinking of. The
Okay.
other thing before I forget is omega-3 fatty acids.
Oh,
Some people do ask about herbal options. So omega-3s have been the best studied of all the sort of non-pharmacological prescription options. 1,000 milligrams a day with EPA to DHA at a 2-to-1 ratio is the research that gives it an effect size that's not as good as medication, but is better than placebo.
so wait,
Um,
you said omega-3 fatty acids
yes, at
and
1,000 milligrams a day.
1,000 milligrams a day. And what was the ratio?
EPA to DHA at a 2-to-1 ratio.
Okay.
And I want to acknowledge omega-3s are herbal, so you might not find it exactly like that, but at least you have a benchmark to try to aim for.
And then someone with ADHD might take that omega-3 supplement once a day in the morning.
Yes,
Okay.
yes.
Wow, that's so interesting. I'd never heard of that. Yeah.
And then the other key thing when we're talking about non-medication treatment options, this is also part of the executive functioning stuff. Structure, structure, structure. You
Oh,
get up at a certain time, you go to bed at a certain time.
oh.
You do your exercise and you eat properly. If you skip a meal, executive functioning is not going to go well, and ADHD is going to be more adversely affected.
Mm, I see. Um, yeah, so this is the YouTube Jessica McCabe's YouTube channel. So she has stuff like how to motivate your brain, ADHD friendly house hacks, how to organize your house. She has a TED talk called "Failing at Normal." What I would tell my younger self. Ah, very cool. I'm gonna check that out later. Um, what was the other executive functioning training resource you said? Did you mention that?
cbtskills.ca.
Okay, CBT skills. Let's see. Here it is, cbtskills.ca. And there's one, is there one specifically for
I
AD?
don't, yeah, there is one that is for ADHD. I don't know if it's right here yet. I know last year they were doing the pilot projects with the groups to see if it was going to be well. Oh, look, I see it now. Oh, it's lovely.
Yeah,
Yes,
skills
that's
for
it.
success, ADHD strategies for adults. And this is
Yes,
probably just open to British Columbians, yeah?
yes. And
Okay.
it is run by psychiatrists and family physicians like the other CBT groups for anxiety
Oh, I
or
love this.
depression.
They even have a booster group for self-compassion.
Yes.
That's so cool.
This is a wonderful program because if you have done any of the level ones, then you can access level twos, as you saw. There's different levels of
Mm,
cognitive behavioral therapy.
that's so cool. One of my friends, I believe Joanna Cheek, was working in
Yes.
this
Oh, she's
program.
core. Yes. Yes.
Is core like hardcore?
No, she's core. Like I believe she was one of the core people who was instrumental in developing this.
Got it. Got it.
Yes. I won't name drop, but yeah, no, the people who do the cbtskills.ca, including my beloved colleague. I didn't ask permission to mention her name, so I won't, but she it was instrumental in the skills for success.
That's so cool. I'm gonna take that one as well. I'm gonna register. I know I saw a physician's box, so I'm gonna do that. Um, what else do you think viewers need to know about ADHD? Anything we haven't talked about yet?
I think we actually reviewed a lot of
We
things.
did.
Um, Societal expectations. I mean, I think a really important part, which many of my people with ADHD actually haven't thought of this either. If you've lived with ADHD your whole life, a lot of times you've been diagnosed with anxiety, depression, and then it's not working, and the counseling's not working. So now you feel like you're a failure at counseling. And and then, you know, happenstance is often the case. You come across there's ADHD in the news. There's more documentaries about it now. There's more readings about it. And but you're still thinking that it's mostly hyperactive kids running around disturbing others. And that's a myth that we talk about. But then the other thing I think, which is important for practitioners too, is you don't know what it's like not to have ADHD. Unlike people who come in saying that they have depression, they can clearly say, I used to be depressed, or no, sorry, I used to be not depressed. This is my usual self, and now I'm depressed. You have a comparison. With ADHD, it's a bit more difficult to tease out because many people say, I've just been like this my whole life. And so there are certain things that you can ask about to try to get the clues, and you can use the ASRS and the Wender Utah to help guide you. Lots of times when I start just asking some of those ticky boxes on the Wender Utah, it jogs their memory, and they'll be like, well, this happened to me. And so a lot of them will say, well, I don't think I was depressed, and I don't think I was trying to be a bully, but I would just like, I was that person who just like shot off. And, I've got this foot and mouth syndrome. So I lost so many friends. And, they talk about, I wish I hadn't said that. Now I'm in trouble again. Right. So this is the story of their life. And they're often diagnosed with not ADHD and feel like they have a character flaw. Now, I want to put out there, of course, learning how to be more emotionally regulated and having those skills is helpful. So it's not that we don't think that it's not helpful to conceptualize the psychology of it or how it's impacted on you. And then how, yeah, maybe we're more sensitive, right? Because we've been told all our lives we're doing things wrong. That also can make us more reactive. But it's not in a character flaw or your fault kind of way. It's more, and let's try to understand the whole you and how has ADHD affected, sure, how you've managed when you're feeling bad. Those might be two different things, but we can acknowledge that, yeah, the untreated ADHD contributed to this maladaptive pattern of functioning. And that is not about fault. That simply is what is. And how do we deal with it now? And it's not all about medication either. Yeah. Although medication can help you focus and concentrate to do the counseling.
It's interesting how you mentioned that foot and mouth syndrome could be one of the nasty impacts of ADHD. So there are people who have impulsive verbal outbursts, maybe.
Yes.
Yeah.
Yes. You
I've
know,
I've actually had patients complain to me of that, and I wasn't certain that what to do. And now I realize maybe I just need to assess them for ADHD. So,
sure. And the first step could be hopefully, and I want to acknowledge, right? Time consuming, right? To try to sort this out, but you don't have to do it all at once. You can do it in like 3 or 4 bite-sized pieces, which is one of the things actually I have been involved in is a kind of, it was a shared care project. But training interested GPs and NPs in how to diagnose and treat uncomplicated ADHD in your office practice that's reasonable and feasible for a busy primary care clinician, right? In bite-sized
mhm.
pieces. So when somebody comes in and says, oh my goodness, I'm always late and I can't get things done, and the kids are all, and I have foot and mouth syndrome, instead of saying, oh my goodness, I better refer you to someone, or like, oh, isn't this like how we all are now? Right? They may be both poor parts. You can say, hey, here's an ASRS and a Wender Utah. Fill this out and we'll see what it says. And then the next step can be reviewing it next time.
I thought of another myth that I would love to bust before we finish this call. The myth is that the pharmacotherapy for ADHD is very dangerous and addictive, and dangerous, addictive, and will change your brain forever and change your personality. Can you speak to that myth? If it is a myth?
Absolutely. Sure. I can speak to that. I I will acknowledge, like as with any treatment, there are risks. And some of them would be very rare, and some of them may be more common, like the risk of losing your appetite, let's say, with a medication like a stimulant would be more common, but not necessarily, for most people, not dangerous, right? So here again, we are going from here to here, not from here to here. And when we're here, right, there are the things which are dangerous with non-treatment. So when you treat, I'm going to quote some numbers now. If you treat 4 patients with ADHD, properly diagnosed, treating ADHD, there is 1 less motor vehicle accident. So what is the risk of untreated
Wow.
ADHD? The risk of untreated ADHD is much higher risk of motor vehicle accident, smoking cigarettes, substance use disorder, and depression. I mean, there's other things which are risks, higher risk of obesity. So there is a risk, yes, of the medication, but I'll just put one thing out there. Many people are worried about cardiac status. Yes, yes. But the risks in a healthy person with no history of cardiac disease, with stimulants causing cardiac disease, this has been well researched in studies, is actually nil. There's actually no evidence. Okay. Now, if you're actively having a heart attack in your 70s, I would probably not give you your stimulants that you've been treating your ADHD with that was well treated. I would probably, no, it's not a good time to treat the ADHD. We got to, reduce the battery on your heart, right? Because the ADHD medication is a stimulant. It can stimulate your heart a little bit. All right. So yes, there are risks. Are these medications dangerous? Not if they're used properly and used in a properly diagnosed person with ADHD at the right doses, and you're using the appropriate monitoring for whatever you need to monitor for. So I won't go into details for that here, but I will say the monitoring is actually not generally like onerous. It's not like we have to get blood work every week or nothing like that. Okay. But I do want to pose the question, what are the risks of untreated ADHD? And that's actually been very well documented societally, with lost income, loss of wages, incarcerations, lack of academic success, lack of occupational success, increased social difficulties. The list goes on.
And almost everything that you just mentioned just now applies to untreated anxiety and untreated schizophrenia, untreated depression.
Yes.
So it's a
Yes.
mental health challenge just like any other. Mm.
Life.
So ADHD medications, when dosed properly, are safe and actually reduce a patient's morbidity, and in some cases reduce their mortality.
Absolutely.
And
Yes.
in some cases, you said it can, if you treat 4 people who drive who have ADHD, you could reduce 1 car accident. Is that what you said?
Yes.
That is
It is what I said.
that's very
And
cool.
that's and I'm quoting a research paper on that. I will say I've had patients who have come after they've been diagnosed with ADHD who actually did not want to take the medication, right? They were worried about the risks. They didn't want to become addicted, all sorts of fears they had. And they came in with tears in their eyes because they, for the first time in their life, could go home at 5 p.m. from work, not 8 p.m. 3 hours of overtime was what they typically did. They could finish their work and they were like, oh, I just did it without having to. I just did it. That's never happened before. It's life changing. They've said
Yeah,
that their life has changed.
because they have more ability to use their intention. Mm.
Yes. Their cognitive battery is now at a similar level to their peers.
Wow. Thank you so much, Betty. I really appreciate you coming on the podcast today. I think a lot of people are going to resonate with this topic and learn a lot from you. So I really appreciate you.
Thank you so much, Lawrence. Thank you for your time and your efforts.